Good morning. My name is Elizabeth Casiano, and I'm a physician with UT Medicine at the UT Health Science Center in San Antonio. I specialize in female pelvic medicine and reconstructive surgery. Today we'll be talking about pelvic organ prolapse and urinary incontinence in women. This is a very important topic because it affects so many women, and there are good treatments available. So what is prolapse? Well, prolapse occurs when there's a weakening of the ligaments and strong tissues that hold up a woman's pelvic organs. This weakening allows structures to drop down or prolapse, which would be similar to what we think of as a hernia. This occurs due to age, having pregnancies and deliveries, loss of estrogen, and doing activities over time such as chronic coughing, straining with bowel movements, and lifting heavy objects. So to think about prolapse, we should think first about the normal female anatomy. This diagram here is a picture of a woman as if she's cut in half, looking from a side view. We see some landmarks, such as in front, the pubic bone, next, the urethra and bladder, following that, the vagina and uterus, if still present, and finally, the rectum and anus. First, we have uterine or vaginal vault prolapse. This uterine prolapse occurs when the ligaments holding uterus allow it to drop into the vagina. The same thing can happen with the vaginal vault, or top of the vagina, if a woman has already had her uterus removed. As physicians, we rate the severity of this prolapse from 0 to 4, with 0 referring to no prolapse at all, and 4 meaning complete prolapse or complete eversion of the tissues. Cystoscopy is a hernia of the anterior vaginal wall, which allows the bladder to sag or drop into the vagina. This can be graded in severity in the same way as the uterus, and can also lead to difficulty emptying the bladder and at times recurrent urinary tract infections. This picture is of a rectocele, which is similar to the cystoscopy, except as opposed to the anterior wall like we saw before, now we're talking about the posterior or back wall of the vagina. That relaxes and allows the rectum to bulge up and into the vagina. It's important to differentiate this from rectal prolapse, in which you actually have rectal tissue protruding from the anus. So what are the symptoms of prolapse? Well, it's also important to remember that many people have a combination of the different types of prolapse. Therefore, their symptoms are going to depend on which part is worse. Often, women will feel some bulge or pressure in the vagina or pelvic area. They may have difficulty emptying the bowel or bladder. They can have recurrent urinary tract infections or vaginal bleeding. And they can have discomfort with or inability to have intercourse. There are many women who also have no symptoms at all and may only find out that they have prolapse when they're being examined by a physician. When should a woman seek treatment? Again, prolapse and fixing prolapse is really about your quality of life. So the time to fix prolapse is when it's bothering you or interfering with your activities of your daily life. If you have recurrent urinary tract infections, it's important to see if the prolapse is playing a role. And if you have vaginal bleeding, although this could just be from irritated vaginal tissue, it's important to see somebody to rule out more serious things such as endometrial problems. The treatment of prolapse can be divided into non-surgical and surgical types of treatment. Again, the first thing to think about is that this really only needs to be treated if it's bothering somebody. So again, we're doing this for quality of life. If it's not bothering anybody, they're not having any symptoms from it, patients can just be reassured, nothing needs to be done about this, and we can observe this over time. At any point when this does become bothersome, then we can talk about treatment. Going along with this, vaginal estrogen cream can be really useful, especially if we're not going to do anything, and also if patients do want to seek other treatments. That estrogen cream is going to keep that vaginal tissue nice and healthy, keep it from getting irritated or bleeding, and can also make it easier to do things like pessaries and surgeries. The estrogen cream itself is not going to make your prolapse go away, but it can help strengthen that tissue there and make it more amenable to having treatment. Kegel exercises and pessaries we'll talk a little bit about in the next slides. Pessaries are a type of rubber-like device that sits inside the vagina and holds things back up when they're falling down. This isn't a permanent type of procedure in that it's something that's done in the doctor's office, placed by somebody who knows sort of how it should fit and what type would work best for them. When that's in place, it's going to hold everything back, but when it comes out, that prolapse is going to return to how it used to be. As you can see, there's many different types of pessaries. And those are all different shapes and sizes. I've shown some pictures of those there. And the picture of the right is showing a pessary that's put in place. So this pessary is holding back the uterus, as you can see. And this is actually a special type of pessary that also has a knob that sits under the urethra. and that's used for prolapse as well as incontinence, and we'll talk about that a bit later as well. So what are Kegel, or some people call them Kegel exercises? And these are exercises of the pelvic floor. You have levator muscles that sit at the base of the pelvic floor, and you're squeezing these muscles. And the goal there is to isolate those muscles, keeping the abdomen and buttocks still. A good way to test to make sure that you're doing those properly is to sit on the toilet and see if you can stop your flow of urine. And that's what really you should be doing, squeezing those muscles that allow that to happen. And that's not a place that you want to be practicing on the toilet, trying to repeatedly stop your urine, because that's not a good habit to form. But every once in a while, to check to make sure you're doing that exercise properly, you can go ahead and do that. And to keep those muscles nice and strong, about 10 repetitions, 3 times a day. And that's more to prevent future prolapse or prevent progression of prolapse. It's probably not going to make it go away entirely. And this is something you can use for urinary incontinence as well, and we'll talk about that a little bit. So surgical treatment. There are different types of surgical treatment, and the first thing to think about is the approach, whether we're going to do that vaginally or abdominally. The vaginal repair is something that's often used as a first-line treatment because it's a little bit easier to recover from and a little less risky than having an abdominal repair. And once you decide on a vaginal repair, the next question is whether or not you want to use native tissues, meaning your own tissues in a series of sutures, or use a synthetic material called mesh. Using the native tissues, that's something, again, often done as a first-line type of treatment. And the repairs with mesh is something that maybe provides a little bit more durability, but also has some downsides to go with it. The vaginal repair with mesh is something that's been in the news a lot lately because it has been causing women problems. And I will say, I think it's important to do some research beforehand and talk to your provider about this. But there are definitely some women who would benefit from having the vaginal repair with the mesh or that synthetic material. And that should be decided on a case-by-case basis, but with you and your provider. The vaginal repair often will include a hysterectomy if the uterus is still present. So that's something you should expect as part of that surgery, or at least talk to your provider about. The abdominal repair with mesh has been around a long time. Using mesh abdominally doesn't seem to cause as many of the same problems as the vaginal repair with mesh. And there still is some complications that can be associated with mesh, but again, that's less common. And the abdominal repair, it's important to remember that you might have a little bit tougher recovery, at least in the initial portion. And having an abdominal incision does increase your risk a little bit, but there are people who are good candidates for this. Again, having that mesh or synthetic material will add a little bit of durability to repair, so that's something to think about. So what are the risks of surgery and recovery time? Again, this is a major surgery. Most of these procedures are going to require a 1 to 2 night hospital stay, and then some type of restriction afterwards. Generally, what I tell patients is about 6 weeks of not lifting more than 10 pounds, no intercourse, and no exercise. So that's a significant something that has to really going to change your life for the next 6 weeks. And your energy level probably won't be back till about 80% by about 6 weeks. So this is a major type of procedure. Risks in general of these types of procedures would be bleeding, infection, injury to surrounding organs, which in this case would be your bowel and your bladder, recurrence of the prolapse itself. You could have problems emptying or urinary incontinence, some pain, and again, if you're using a synthetic material called mesh, problems with the mesh, such as a mesh erosion. All right, so now we're going to move on to urinary incontinence. And when I use the term incontinence, basically what I'm talking about is an involuntary loss of urine. This is very common in both men and women, and we'll be focusing on women because that's what I specialize in. In women over 65, the prevalence is high, somewhere between 30 and 50%. And again, the reason we talk about this is because it does cause significant bother, high costs of incontinence supplies, and at times can even lead to admission to nursing homes, either because the patient or caregiver is unable to care for this, and it can be a significant bother to them. What are normal voiding patterns? The bladder itself basically has 2 functions. It stores urine and it voids, or empties the bladder. Daily number of voids should be less than 8 times per day, and average is about 4 to 6. This comes out to be about every 3 to 4 hours during the daytime. Nighttime, it's normal to go either not at all or once during the nighttime. And a normal bladder capacity is about 300 or 500 cc's. And it's important to remember this bladder capacity because I think of the bladder as sort of like a ball of rubber bands. If you think about a rubber band that you're stretching and comes back together on a repeated basis, at some point if you overfill that bladder and stretch out that rubber band all the way, it's not really going to want to come back to its original shape. It's going to lose its elasticity. And that can happen with the bladder if you're overfilling it. I have a diagram here that's basically showing the relation of the brain and spinal cord to the bladder itself. And basically, when you're having a filling, you have a sensation that's coming from a signal from the brain, traveling down the spinal cord, and that's going to let the bladder relax, and the bladder neck that's holding that bladder between the bladder and the urethra, where the urine comes out, squeezing that, allowing it to fill. And that allows you to have a nice big bladder so that you're able to fill to that 300 or 500 cc capacity. Going the opposite direction for emptying the bladder, now you have a bladder telling the spinal cord that it wants to empty, and it's full, it needs time. And basically, yeah, it's going to send a signal to the brain. A signal will come back from that big bladder, and now that bladder muscle is going to squeeze and empty out. There are many different types of incontinence. I've gone through just some of the more common types of incontinence. First being stress incontinence, and that's leakage associated with an effort or physical exertion. So when I say stress, I'm not talking about the stress that you think of with a big exam coming up or something you're nervous about, but the actual physical exertion. So coughing, laughing, sneezing, doing exercise, lifting a heavy box, those types of things are going to directly lead to leakage of urine. Urge incontinence is leakage associated with an urgency to go. So this is the gotta go type of sensation where you get an urge and you don't have the warning time to get there in time. Going along with urge incontinence, people go more frequently, and they might have more frequency at nighttime, called nocturia, meaning you're going more than those 0 or 1 times per night. Mixed incontinence is really common, and that's having a combination of those first two, stress and urge. And most women that I see probably have a component of both of those there. They may be able to say that one is more bothersome than the other, and that's important because that will tailor how we treat them. It's important to think about overflow incontinence, rule that out. And basically in this case you're having incomplete bladder emptying, so that bladder never empties out and you're leaking out sort of the overflow or what's left and can't come out. Functional leakage refers to simply inability to get to the toilet. So either because of problems actually moving, getting to the toilet, or a cognitive impairment. You're not making it to the bathroom in time and you're leaking because of that. So first, going through treatments of stress incontinence, those Kegel exercises that we talked about a little earlier, squeezing those same pelvic floor muscles, and if you've heard the term, the squeeze before you sneeze, that's the same type of deal that we're talking about here. So when you're ready to pick up that heavy box or do the activity that's going to make you leak, you're going to squeeze those pelvic floor muscles so that you can keep that from happening. And again, there are special pessaries that you can fit. Those will have a little knob that sits under the urethra. And what that does is basically provide some resistance so that when you do those activities, then you can't leak urine from the urethra. The next three I have actually some pictures of, so we'll go on to the next slide. That first picture there on the left shows a sling procedure. That's a piece of synthetic material that sits underneath the urethra, and that's placed in an operating room, and that's done usually on an outpatient surgery type basis. So you come in that morning, surgery itself takes somewhere between 30 minutes and an hour, and you go home later that day. Again, this is providing some resistance to the urethra, recreating those ligaments that used to be there that have now relaxed and allow urine to escape when you do an activity. That picture on the top right is a picture of the bladder before and after collagen treatments or urethral bulking. Collagen is just one of the materials that you can use to do this. And basically, again, you're tightening that area around the urethra, providing some resistance so that urine doesn't leak when you have an increased abdominal pressure with coughing, bearing down, and again, those sorts of activities. And finally, that little device in the bottom is a urethral insert or urethral plug. And that's something that women or caregivers can actually place, and this is meant to be a temporary fix. So this is really good for women who have specific discrete times of leakage. So you're fine for the majority of the day, but then when you go do your morning walk, you have a lot of leakage associated with that. That's something that you can place just before you go on your walk. It's going to hold the urine in for you so that you don't leak. And then you pull that out and you can void normally for the rest of the day. Moving on to treatment of urge incontinence, again, those Kegels come back again for us. So they're really useful in many different things in this area. And this type of Kegels we're going to do is called urge suppression. So that's more of a quick flick, or you're squeezing, relaxing in a more of a quick manner. So when you get that urge and you think you're not going to be able to make it to the toilet, you're going to sit, instead of rushing to the toilet, sit down and squeeze and release those muscles and see if you can get that urge to give you a little more time to get to the bathroom. The second thing is avoiding bladder irritants. So these are things that you eat or drink that can really affect the bladder and make that bladder muscle want to squeeze more than it wants to, more than it should. There's a bunch of different bladder irritants, and they're different for every person. Their bladder is going to react differently to these types of caffeine, carbonation, citrus fruits. Some people may react to caffeine where others don't. So generally what I do is I give patients a list of these things and tell me, is there something on there that you do a lot of? You're like, okay, well I have 3 cups of coffee in the morning, and then I find that I have a lot of urgency and urge incontinence. Maybe cutting back to 1 cup of coffee, or doing it around the time that you know you're going to be home anyway and it's not going to be bothersome. Again, this all goes back to quality of life. So if you're knocking out all these things and now your bladder works but you're unhappy because you're depriving yourself, then that's not worth it either. So just something to think about. The next one, time voids. That's something that can be done for people who either aren't going enough and having leakage because they're not going enough, or people who are going very frequently and their bladder's kind of gotten to the habit of not being able to stretch out. So depending on what your problem is how you would go about this. So time voids for somebody who's going too often is basically, now let's say you're going to be going, somebody who goes every 30 minutes. You want to try to increase that, maybe by 10 or 15-minute intervals, so that you, at the 30-minute mark when that bladder starts to squeeze and wants you to try to empty, you can try to do some Kegels. Sit down, think about other things, do your Kegels, and see if you can't get that to expand up to 40 minutes or 45 minutes. And then go on from there. And at some point you can go from the 30 minutes, going every 30 minutes, to maybe now you have 2 hours. And really you just want to get to a point where it's not so bothersome. For example, you want to go to a movie and you want to be able to sit there for 2 hours, then that's kind of the goal that you want to set for yourself, to get from 30 minutes to 2 hours. If you're not going enough and you find that it's been 4, 5, 6 hours since you've gone, of course you're going to leak because you've got way too much in your bladder. So you really want to set a timer so that you say, I'm going to be going every 3 hours or every 4 hours and make sure that my bladder's empty. Sometimes even going every 2 hours. It's not so excessive that it's keeping you from doing your activities, and it's enough to keep you from leaking urine. Medications, the classification of most of those medications is something called anticholinergics, and we'll talk about that a little more on one of the next slides. That's a good option for treatment. And then once all those top 4 things have failed, then you're going to move on to other things. So the last 2 I have listed are when you get to that point. So the first one being Botox, and that's the same type of thing that you would inject for wrinkles. It's basically a muscle relaxant or paralytic of the muscle. And you can actually inject that into the bladder muscle itself, and that'll help it from squeezing as much as it wants to, as it's trying to squeeze. It's something that unfortunately is not permanent. People are a little bit different in terms of how often they need to have their Botox redone. And there are some side effects. People can have so much Botox that their muscle is a little too relaxed and they're not able to empty. Again, because it's temporary, that's not going to be a permanent problem, but it's something that you need to consider when you're thinking about having Botox done. And the final one, the sacral neuromodulation, is basically a pacemaker for the bladder. And I have some pictures of that. We'll go into that in a little more detail in just a minute. So those anticholinergic medications, there's many different brands on the market, and you've probably seen some of the commercials for some of them. And basically what the goal of these is to increase your bladder capacity. You block the receptors in the bladder so that muscle is not squeezing as much as it needs to, and that allows the bladder to fill, and again, fills more so that you're not going so often and you're not having to rush to the bathroom. So the goal of this medication is to decrease the number of voids and leaks. Main side effects of these medications are dry mouth, constipation, and some of them can have effects on your memory and cognition. Most people are pretty open to having it. There are not a lot of contraindications. The only major contraindication is having the uncontrolled narrow angle glaucoma. So that's something that if you're going to see a provider, probably some good information to have, knowing your medical history in terms of your glaucoma history. There are a few other contraindications, but this is probably the biggest one that keeps people from having the medication. And it's not a very common thing that people have, so that's the good thing. The sacral neuromodulation or pacemaker of the bladder. That picture on the left shows the actual little battery pack that's placed into the buttocks. And the picture on the right is basically showing the lead placement. So you have a little wire that's placed in through the back. And that basically just sort of resets the bladder so that it's not squeezing so much, again, allowing it to better fill more easily and keeping it from squeezing as much so you're not having such urgency and leakage associated with that. That's done, can be either done at a provider's office or in a hospital setting, depending on your provider's preference. And that's something that works really well. Again, that's for somebody who basically has failed a couple of medications, has failed the Kegel exercise, and is still really needing something else for their bladder urgency and urgent continence. It can also be used, which is something we're not talking about today, but in urinary retention, and is now being helped for people who have constipation or fecal incontinence. And that's, again, another topic for another day. Finally, I'm going to talk a little bit about what you would expect when you decide to seek medical treatment. First of all, a detailed discussion of your symptoms and urinary habits. And these are things that a lot of people haven't thought of before. So I'm telling you this now so that if you see a provider, this is something you can think about beforehand. Avoiding diarrhea is something that can be really helpful. Basically, it's a sort of written down description of maybe over 1 or 2 days where you're telling people how much you're drinking, how much you're voiding, when you're leaking, and what's making you leak, because that's really the important thing. Once you figure out the type of incontinence, then you can tailor your treatment to what's really bothering you. Of course, a physical exam, and what people will be looking for is sometimes you can actually see leakage while the patient's in the office. And then looking for prolapse. If there's symptoms or not, seeing if there's prolapse will help you decide how to treat prolapse and incontinence. A urinalysis is a good idea for somebody who's either had prolapse and isn't emptying their bladder, and also somebody who has urinary incontinence, because even just something as simple as a urinary tract infection can cause urinary incontinence. Some physicians may ask you to void and have you check for a post-void residual, which basically is some method of seeing what's left in the bladder after you go normally. This can be done either with a little bladder scanner, which looks like a little ultrasound machine, or as simply as passing a little catheter to see what's left in the bladder. Finally, sometimes it's indicated to do some other studies. So there's the next two. I'm going to go into a little bit more detail in the next slides, the cystoscopy and urodynamic studies. So cystoscopy can be indicated in many different reasons, and again, every provider has their own preference as to when they'll do their cystoscopy. Often if patients have urgency and frequency, especially if it's not sort of responding to some of the usual medicines or treatments that we've talked about. If there's blood in the urine, if they're having recurrent symptoms after a treatment that's already been done. Also things like history of stones or just sort of stories that don't quite make sense. Always a good idea to take a look in the bladder and rule out things. What we'd be checking for is some foreign bodies, injuries to the bladder from prior surgeries, and we want to rule out bladder cancer. It's not very common, and it's definitely not the most common cause of these symptoms, but if we're concerned about it, then that's something that would be easy to do in the office. And basically what the cystoscopy is you're using a little thin scope that it may or may not have a camera on it, but if it has a camera on it, it's kind of nice because you can actually watch it being done as well. And then you place that through the urethra, and you can examine the urethra and bladder with that little camera. Urodynamics is a study done to evaluate the bladder sensation, capacity, how well you void, and then check for leakage because of urge, stress, or overflow incontinence. First, usually what happens is the patient's asked to void on their own, and then there's a series of catheters placed in the bladder and vagina or rectum, and finally the bladder is filled and maneuvers are done. So having you cough to see if we can see a leakage, or seeing if that detrusor muscle or bladder muscle is overactive. These are all things that we can tell in urodynamics, and especially if there's any question about prior treatment or question about the type of symptoms, this can be really helpful. So I hope you've enjoyed this presentation and learned something today. If there's I believe there's a little bubble placed on your screen, and if you click on that, it'll set a link to ask any questions you have for me today.